We'll be talking about long leg and what causes it and the effects of a long leg, although we've talked about causes before. If you're wondering about short leg, we'll do that separately. But I think long leg is more common. I also think it's more consequential than the short leg problem is. And once we understand long leg, short leg will be a doddle. So before we start this, though, I want to talk a little bit more about intra-unit problems in the ankle foot and the lumbopelvic regions, and they will help give some insight into the effects of long leg as a quadrant syndrome. Okay, let's have a look at the effect of a over-flattened foot, a collapsed foot, hyperpronated if you prefer. The foot is flattened out for whatever reason. This results in everything medially rotating, certainly from the knee down. So you get stress on the medial side of the foot, stress on the lower part of the tibia, stress on the medial side of the knee, and also because of overdorsiflexion of the ankle, stress on the superior tib and inferior tib fib joints. So all of these areas are prone to damage. Now what's going to happen is that the muscles that hold the foot up, that tend to invert the foot, particularly tibialis anterior, will contract and they'll try and hold the foot up. So if we look at the potential damage that's done here, we could see MCL problems, medial compartment problems at the knee, and the MCL problem can be quite severe. You can actually get a straight instability, which is normally considered a grade 2 tear. But these are not so much tears as they are overstretched ligaments. They're incompetent, but they may not actually be an inflammatory process or a tear of any kind. It may tear because of degeneration, but it may not tear. So it's one of those instances where the term strain may actually be a reasonable one, where there's no discontinuity in the ligament. So the medial ligament can become incompetent, the medial meniscus can tear, there can be extra stress on the cruciates as well. Moving down, you're prone to tibial stress syndromes, either stress or a stress fracture in the lower part of the tibia. That medial rotation occurs. And at the ankle, the medial collateral ligament can become overstretched again. And in the foot itself, we can start seeing plantar subluxations, evertant subluxations of the cuboid, overstretched plantar fascia. At the ankle, the foot tends to overdorsiflex with this medial rotation, and so what you see there is separation of the tib fib over a prolonged period, and that tends to stress out the anterior cruciate ligament, and the superior tibial joint also takes a beating as that's getting pushed up and backwards. So all of this doesn't help much. Now, these can be normal compensations. So you may not get any symptoms from this. You may not even get any damage. If this is all perfectly compensated for, then there may be no damage occurring. But if, for example, say the ankle itself, the talus was subluxed into medial rotation, or if you like plantar flexion, and can't dorsiflex to take its role in this, then all of those stresses on the other joints will be amplified, and all or any of them can become manifest in the form of symptomatics. And these are also clues as to what's happening, because if you do have a flat foot and you're trying to find out what's happening there, it's worthwhile palpating these structures. Simply because if they are more sensitive than the other side, for example, then it's reasonable to assume that there is this type of stress going on. The tibialis anterior and other anterior tibials trying to hold the foot up can be overworked, again, especially if other joints are not involved in the compensation, and these become degenerate, and you can get tendinosis or even degenerate tears in these muscles. Let's have a look at the other end. Here we have hip extension hypermobility, whether it's from subluxation, arthritis, whatever it is, we have a hip extension hypermobility, and the patient insists on demanding full extension from the hip. So this is going to be fast walking, running, other sporting activities that require that. So this is not likely to bother a sedentary worker, but it's somebody where that extension stress is required. but you've lost extension. So that extension has to be gained from elsewhere, and it's going to be gained immediately within the same unit. It will be gained at the SI joint with the innominate anteriorly rotating, that is extending more because the hip can't do it, and also at the lumbar spine, where you'll see an increased lordosis as you lose that extension below. So what you actually see here is an extension subluxation of the SI joint, potentially, and an extension subluxation of the right L5-S1 in particular, but also L4-5 less commonly. Now again, you can imagine if this force is amplified, if the SI joint is unable to extend to compensate for this, then you're going to get more extension at the SI joint. If the lumbosacral junction, sorry. If the lumbosacral junction is unable to extend what the SI is, the chances are not that the SI is going to be problematic mechanically, because the masses between the two are so greatly different, but more likely L4-5 is going to be damaged, and possibly L3-4. So this is a transfer of abnormal forces up the chain. In a second, we're going to see how those forces are transferred down the chain as well. Okay, so back to the long leg. What you could see from the previous slide was a collapsed foot is going to shorten the leg, obviously. A MCL tear will also shorten the leg because it will allow abduction of the knee to occur. So these are also compensations for a long leg. So if we look at the cause of a long leg, it's a foot that can't pronate. So we have a foot that's held up into supination or inversion. The knee doesn't play a big role in the lengthening the leg. It can shorten the leg, but it really can't lengthen it. So if you've got a fully mobile knee, a stance is where all of these forces are maximized. Stance phase of walking or running. So the knee is fully extended at that point, and that's as long as the leg gets as far as the knee is concerned. If it moves in any direction from that optimal full extension, that is, if it comes backwards, as it will do if you lock the knee back, you'll actually shorten the leg. If it abducts, it will shorten the leg. If it adducts, it's not going to make that much difference to the length of the leg. It will try to do that with lateral rotation, but it doesn't make that much difference to the leg. So the knee doesn't play a huge role in compensating for a long leg. It plays a role when it overcompensates and breaks down, but as a compensatory mechanism, it doesn't play a big role in it. The ankle will try to dorsiflex more, and the hip will try to flex by the innominate rotating over it, and the spine will side flex to the long leg side. That is, it will form a concave side of the scoliosis that occurs because of the long leg. They're all compensations for a long leg. Again, if any of these compensations can't take a role in it, if any of these joints can't take their role in compensate for a long leg, the stresses fall more on the more mobile joints, and they can start to overcompensate. That is, they can start to break down. So what will compensate a long leg will also shorten a normal leg. So a flattened foot will make the leg shorter, an abducted knee will make the leg shorter. An extension subluxation, a primary extension subluxation of the SI joint will flex the hip and make the leg shorter, as will an extension subluxation of the lumbar spine. All of this will tend to make the leg shorter. So anything that compensates for the leg will try to shorten the leg. If they're not compensating and they break down anyway, as we saw with the flat foot we just looked at, then the leg will shorten. So as the right leg is busy being longer than it should be, what's the left leg doing? Well, it's busy getting longer than it should be as well. So what we see on the right leg, which is long, is it trying to shorten. So this is mostly passive. You've got compression from above and below. So you've got body weight pushing down, ground reaction forces pushing up. And the upshot of all this is that the whole lower quadrant tends to immediately rotate. And when these things overcompensate, it's really the joints that tend to break down. Sometimes the bone in the form of stress fractures, like tibial stress syndrome, tibial stress fractures. But mostly it's the joints. They break down because they're being forced past their ability to compensate. So they overcompensate and break down. On the other side, though, this leg is trying to lengthen. It does that by stretching upwards. So if you think about it, the obvious way to lengthen the leg is to extend the hip and plantar flex the ankle and invert the foot. All of that will make you stand on a longer leg. The knee really can't play a major role in this. If the knee has full range of motion, the leg is maximally long when this is at its close pack position, where it's not moved into the hyperextension range, which is normal for it, but where the condyles are on the flattest part of the condyle of the femur is on the flattest part of the condyle of the tibia. So you get maximum articular surface contact. Any movement away from this will tend to shorten the leg, whether it's hyperextension, abduction, flexion. It tends to shorten the leg. Now, sometimes adduction may lengthen it a little bit as a whole leg laterally rotates to lengthen, but doesn't do an awful lot there, but it does move it towards its maximum length. So this is what's happening on the right side. The leg is medially rotating, the long side, and on the short side, the left side, it is laterally rotating. And unlike the right side, where it's nearly all passive gravity and ground reaction forces, this is about muscular activity. So in order to get the pelvis to flex on the femur and so extend the hip, the hamstrings are going to be active. And in order to get the foot a little bit plantar flex as much as it can without overusing it too much, the plantar flexors are going to be active. And for the inversion of the foot, the anterior tibials, particularly tibialis anterior, are also going to be active. So you get an active response to a leg that's shorter than the other leg and needs to lengthen to compensate for the long leg. At the same time, these same strategies will take a leg that is of normal length and lengthen the leg if it need be. But in fact, usually what happens is the leg lengthens because of a subluxation that makes the leg go long. For example, the ankle with a medial talar subluxation, or if you like an anterior talus, will produce plantar flexion. Dorsal subluxation in the foot will produce inversion of those joints. So the pathological lengthening of the leg as a cause of problems is more passively done, but when it's adapting for the long leg, it is active. So to recap what's happening in both legs, what you're seeing here is on the left-hand side of the slide is looking at the lower quadrant from the front, and on the right-hand side from the back. So we've got the long leg on the right side, the shorter leg, not necessarily a short leg, but the shorter leg on the left side. And this is what's happening to the long leg. The innominate on that side will extend, thereby flexing the hip, shortening the leg. The knee will tend to abduct and hyperextend, again shortening the leg, and the ankle will tend to plantar flex and also evert. The heel will evert and the whole foot pronate, so it flattens out. All of that will tend to shorten that leg. Now, if everything's working fine, this is compensation and there's no problem with it. If everything is not able to involve itself in this compensation, then the other joints are likely to overcompensate and break down. So often the patient's symptoms are from the breakdown of an overcompensated joint, while the cause of it is whatever is making that leg long. On the short side, you see lateral rotation of the leg, eversion of the heel, and basically flexion of the innominate, extending the hip. There tends to be a slight adduction of the knee as that leg rotates. So as I said earlier, if you stand up, look at your legs, twist to the right without rolling over onto the sides of your feet or the medial side of your foot. Just twist, and you'll see that right foot tend to invert, the long foot invert, and the short foot pronate. If you don't go too far, then it's likely to look a bit like supination, but that's what you see in there. They both move in opposite directions. You'll see the whole leg laterally rotating, and if you palpate things, you'll feel the innominate going anterior on that side. That's it. This is what's happening on both sides. The long leg trying to get shorter, the short leg, or the normal leg, but the shorter one of the two, trying to get longer by stretching out. Okay, this slide shows the effects of overcompensation, where you can expect pain. Not in every case, not in every area, but when a short leg overcompensates or a long leg overcompensates, these are the areas that are going to be most vulnerable to it, in my opinion. So if you look on the right side, you'll see that the medial compartment of the knee gets in trouble. And this is the medial collateral ligament, and you can get straight instabilities from that, not because the force is so tremendous, but because the knee is straight when the instability occurs. So it's not like a traumatic one where the knee tends to flex, you get a rotational instability, or where it's so bad, the trauma, that you go through the cruciates and so on, that will give you a straight instability. This is basically an instability that when you test it with the knee straight, you'll pick up that valgus instability. So technically speaking, that's a grade 2 tear, but it's a little different from the traumatic type. Problems in the calf muscles, Achilles tendinosis, degenerative tears in the calf muscles themselves, plantar subluxations in the foot, particularly at the cuboid. You'll see that sublux into eversion, and of course the SI joint on the right side and the lumbosacral junction on the right side, as these overextend and get into trouble. On the left side, looking from the front, you are likely to see hip joint problems going on there as a result of the other leg being too long, and as a result of that leg being laterally rotated. And you're also likely to see tibialis anterior problems, and again gastric medius problems and lateral compartment of the knee problems, as the calf muscles are trying to basically lengthen the leg by plantar flexing the ankle, and also the tibia and fibula joints as they get stressed out by the ankle, trying to over dorsiflex again to shorten that leg. So these are not only points where it may become symptomatic, these also become important points in determining if the leg is actually long or short, when you can't see it by measurement, because the overcompensation has often made the long leg short. But you can tell by feeling the other areas, apart from actually trying to measure and look for these dysfunctions. So from a clinical perspective, if you're seeing any of these conditions, give the etiology thought, and that etiology may be a leg lengthening problem or a shortening problem, come to that. So essentially, in the last few weeks, we've covered the causes of long leg, the adaptations and compensations you see because of the long leg on both legs, the dysfunctions caused by those overcompensations. Next video, we'll be looking at assessing for a long leg and also assessing for a short leg, but assessing for a long leg, and it's not as simple as it might sound. It's not a matter of measuring this, because using a tape measure really doesn't work very well, or looking at gait or posture. These may give you clues, but they may not, and I'll give you an example of why that is. If I have a long leg and there is overcompensation in that long leg, what I'm likely to see is either a normal leg, so the gait will be normal, or a short leg, so the gait will look like a short leg gait. So what you have to bring to this is palpation, looking for the points that will be tender even if the patient's not complaining of them, and looking for other dysfunctions, even though the patient's not complaining of them. And it's when you find those tender points, say medial collateral ligament is tender compared to the short side, or you find that there is a subluxation of the superior head of fibula, finding those dysfunctions, those tender points, can lead you to properly interpret your clinical findings as far as leg length and scrums is concerned. So, to come. I hope it helped. Take care, everybody. Bye-bye.